In very thin patients, the kidneys may be imaged with the patient in the supine position. For the majority of patients, however, they will need to be moved to a lateral decubitus position so that the kidneys can be interrogated by moving the beam between or under the ribs. The right kidney lies in the crux of the liver. If the probe is placed in the right of midline and angled cephalad to send the beam toward the liver, the kidney may be viewed in long axis. By rotating the transducer 90 degrees, a cross-sectional view of the kidney is possible. The probe can also be placed parallel between the right ribs and angled to image the right kidney through the liver. The left kidney is identified in a similar manner, imaging through the spleen or between the ribs as necessary. In general, it is important to try several probe positions to find a satisfactory window for imaging the kidneys and distal renal arteries. Let's turn our attention to the veins of the abdomen. The inferior vena cava will follow the course of the abdominal aorta, lying to its right side. Superiorly, just distal to the diaphragm, the inferior vena cava gives rise to the right, middle, and left hepatic veins. These veins drain the liver, so blood flow is directed away from the liver into the inferior vena cava. This is called hepatofugal flow direction, with the Latin word fugale meaning to flee. The portal vein carries rich oxygenated blood into the liver. This vein is formed by the confluence of the splenic and superior mesenteric veins. Flow in the portal veins is normally toward the liver or hepatopedal in direction. It is important to note the flow direction in the portal, splenic, and superior mesenteric veins in reference to the orientation of the sound beam. The examiner should also note that the hepatic artery, which we first encountered as it originated from the celiac trunk, enters the liver on the course of the portal vein. Just below the liver, the renal veins will be noted to arise from the lateral walls of the inferior vena cava. Remember, because the cava lies to the right of the aorta, the vein returning blood from the left kidney will normally cross over the aorta to enter the inferior vena cava. As you follow the inferior vena cava to its bifurcation into the common iliac veins, you will note that because the cava is positioned to the right of the aorta, the left common iliac vein will cross under the right common iliac artery. It is thought that the potential for extrinsic compression of the vein by the artery may explain the difference in the frequency of left iliac vein thrombosis compared to thrombosis of the right iliofemoral venous system. Now that we're familiar with the anatomy of the visceral vascular system, let's discuss the ultrasonographic appearance of the abdominal vessels. First, we'll talk about the on-screen appearance of the normal abdominal arteries and veins. Abdominal veins, like veins in the peripheral system, are most often located alongside a corresponding artery. The arteries can be used as landmarks for locating the veins. Remember, the artery is a thicker structure and is noticeably pulsatile. In contrast, the vein has thin walls, and its size and appearance will be quite variable, dependent on the transmural pressure within the venous system. Dramatic changes in vessel size will occur with changes in the patient position and with Valsalva maneuver, which may cause the vein to enlarge several times beyond its normal size. The visceral veins can be best visualized if venous filling is prompted by elevating the patient's head and lowering the feet below heart level. Proximal compression of the vein by kinking, hematoma, or organ masses may also affect the size of the vein. If a segment of the vein above the area being imaged is compressed, flow will stagnate and the size of the vein will increase. Echogenic cellular aggregates may be visualized within the larger abdominal veins. Several of the abdominal veins can be compressed with probe pressure, similar to the more superficial veins of the extremities. The normal vein lumen is echo-free. Thrombus is present when solid echogenic material is visualized within its lumen. As not all abdominal veins will respond to probe pressure due to their depth and angle relative to the skin surface, Doppler and color flow imaging must be used to confirm thrombosis of these veins. Normally, it is possible to obtain sufficient resolution in the larger abdominal veins, such as the inferior vena cava and the portal vein, to allow characterization of thrombus as acute or chronic. You may also be able to image indwelling caval filters. Remember, the features of acute thrombus include lightly echogenic, spongy texture, poorly attached, dilated vein when totally occluded, and smooth borders. The characteristics of chronic thrombus are brightly echogenic, well-attached, rigid texture, contracted vein, irregular borders, and large collaterals. The normal visceral artery is echo-free and noticeably pulsatile. The abdominal arteries vary in size from the large freeway, the aorta, to the smaller intersections, such as the renal arteries, and the small side branches, the vessels within the organs. Plaque can be visualized on the walls of the larger abdominal arteries, such as the aorta, and can be characterized as acoustically homogeneous, heterogeneous, or calcified, and the lesion surface can be characterized as being either smooth or irregular, in a fashion similar to characterization of plaque in the cerebrovascular and peripheral arterial systems.